Hello. I want to ask you something today, and I want you to think about it honestly. Has anyone ever formally assessed your fall risk? Not a general reminder to be careful, not a passing comment about watching your step, but an actual structured assessment where someone measured your balance, timed your movement, checked your blood pressure in different positions, reviewed your medications for fall risk, and asked you specific questions about your history of falls and near falls. For most people over 60, the answer is no. And I think that matters because a formal fall risk assessment is not just a medical formality. It is a specific, evidence-based process that produces actionable information about your individual risk and about what specifically can be done to reduce it. My name is Dr. Chen. I am a physician in internal medicine, and today I want to walk you through what a real fall risk assessment actually involves, step by step, so that you know what to expect and so that you feel confident asking for one by name at your next appointment. Let us begin now. First, I want to explain why this matters enough to dedicate an entire video to. Falls among adults 65 and older are the leading cause of injury, death in that age group in the United States. Roughly 1 in 4 older adults falls at least once a year, and many of the factors that contribute to falls are identifiable in advance, and in many cases addressable before a fall occurs. A fall risk assessment is the process of identifying those factors in your specific situation, not in the average older adult, in you. Because fall risk is individual. What contributes to your risk may be very different from what contributes to someone else's. Some people have medication combinations that lower blood pressure too quickly when they stand. Some have reduced sensation in their feet from diabetes or another condition. Some have a specific balance problem related to their inner ear. Some have weak leg muscles that make catching themselves after a stumble much harder than it needs to be. Some have all of these in varying degrees. A formal assessment identifies which of these factors are present for you individually, and that is what makes it clinically useful rather than generic. Now, let me walk you through what a comprehensive fall risk assessment actually involves. I am going to describe it in the order a clinician, whether a physician or a physical therapist, might approach it. The first component is a fall's history. This is a structured conversation about your recent experience with falls and near falls. A clinician using the CDC's STEADY approach, which I've described in a previous video, begins with 3 key questions. Have you fallen in the past year? Do you feel unsteady when standing or walking? Do you worry about falling? A yes to any one of these triggers a more detailed assessment. Beyond these 3 questions, a thorough falls history also asks how many times you have fallen in the past year, where those falls occurred, what you were doing when they happened, whether there was a specific trigger, such as a trip or dizziness or a sudden leg weakness, and whether you sustained any injury. This history is important because the circumstances of past falls often point toward the specific factors involved. A fall that happened while turning quickly points toward a vestibular or inner ear issue. A fall that happened while walking on uneven ground outside points toward proprioception or vision. A fall that happened when standing up from a chair points toward orthostatic blood pressure changes or lower body weakness. The pattern matters, and a good clinician uses it to guide the rest of the assessment. The second component is a medication review. This is one of the most important and most commonly overlooked components of a fall risk assessment. Multiple categories of medication are associated with increased fall risk in older adults. The CDC's STEADY program specifically includes medication review as a core component because medication-related fall risk is one of the most modifiable factors available. The categories of medication most commonly associated with increased fall risk include sedatives and sleep aids, which affect alertness and reaction time, certain antidepressants, particularly older classes, blood pressure medications, which can cause dizziness when standing, diuretics, which affect blood pressure and fluid balance, certain diabetes medications, anticholinergic drugs, which affect cognition and balance in older adults, and opioid pain medications. A clinician doing a thorough assessment will review your full medication list with specific attention to these categories and ask whether you have noticed any dizziness, lightheadedness, or unsteadiness. That could be related to any of your current medications. This review can sometimes identify a medication or a combination of medications that is a significant contributor to fall risk, and that can potentially be adjusted with the guidance of the prescribing physician. I want to be clear about something here. Medication adjustments for fall risk are never something to do on your own. They require a conversation with your doctor, who can weigh the benefits of the medication against the fall risk contribution and make an informed decision with you. What the assessment does is give your doctor the information they need to have that conversation properly. The third component is the physical performance test. These are standardized, validated clinical tools that measure specific aspects of mobility, balance, and strength that are relevant to fall risk. Let me walk you through the main ones so you know what they involve and why each one matters. The first and most widely used is the Timed Up and Go test, often abbreviated as TUG. This test has been studied extensively, and research has shown it to be a valid and reliable predictor of fall risk, with a strong correlation to the more comprehensive Berg Balance Scale. Here is exactly what it involves. You start seated in a standard chair, with your back against the backrest. The clinician says go. You stand up, without pushing off with your arms if possible. Walk approximately 10 feet. Turn around, walk back, and sit down again. The clinician times this from the word go until you are fully seated again. A score of more than 12 seconds is generally considered to indicate an increased risk of falls in community-dwelling older adults, according to widely used clinical guidelines. Now, I want to be careful about how I frame this, because a single time cutoff does not tell the whole story. The TUG is one piece of information among many. A score above 12 seconds does not mean a fall is inevitable, and a score below 12 seconds does not mean risk is absent. It is one useful data point in a broader picture. That is what a good assessment uses it as, not a pass or fail verdict. The second test is the 30-second chair stand test, sometimes called the 30-second sit to stand. This test measures lower body strength and endurance, which, as I described in a previous video, are critical for balance correction and for the protective stepping response when balance is challenged. Here is what it involves. You sit in a standard chair, arms crossed over your chest. The clinician times 30 seconds, and you stand up fully and sit back down, as many times as you can in those 30 seconds. Your score is the number of complete stands. This is then compared to age and gender normative values, which tell the clinician whether your lower body strength is within a typical range for your age and sex, or whether it falls below in a way that may be contributing to fall risk. The third test is the 4-stage balance test. This test asks you to stand in 4 progressively more challenging positions, each held for 10 seconds. Stage 1, feet side by side. Stage 2, semi-tandem stance, one foot slightly ahead of the other, with the heel of the front foot beside the big toe of the back foot. Stage 3, full tandem stance, one foot directly in front of the other, heel to toe. Stage 4, single leg stance, standing on one foot. Research from the University of Iowa found that the 4-stage balance test was the most sensitive among standard clinical tests for detecting fallers, with 70% sensitivity and 81% accuracy in community-dwelling older adults. This test gives the clinician specific information about where in the balance progression your stability begins to be challenged. Someone who struggles at stage 2 is in a different situation from someone who manages stage 3, but not stage 4. And each of those situations points toward different interventions. The 4th component is orthostatic blood pressure measurement. This is the check for what doctors call orthostatic hypotension, which is a drop in blood pressure when you move from lying or sitting to standing. The medical definition is a drop of at least 20 millimeters of mercury in systolic pressure, or at least 10 millimeters of mercury in diastolic pressure, within 3 minutes of standing. Orthostatic hypotension carries a prevalence of about 18% in older adults generally, and can be significantly higher in specific groups, including those on certain blood pressure medications. When blood pressure drops on standing, the result is often dizziness, lightheadedness, or a brief visual disturbance, all of which can precipitate a fall, particularly in the transition between sitting and standing, which happens many times every day. The measurement involves taking your blood pressure while lying down, then again while sitting, then again after you have been standing for 1 minute, and ideally again at 3 minutes. The differences between these readings tell the clinician whether orthostatic hypotension is present and whether it may be contributing to your fall risk. The 5th component is a vision screen. This does not replace an annual eye exam, but a basic visual acuity check can identify significant vision problems that may be contributing to fall risk and that warrant referral for a full eye examination. Visual input is one of the 3 primary balance systems, and uncorrected vision problems, cataracts, an outdated prescription, or conditions like glaucoma directly affect balance, particularly in low light or on uneven surfaces. The 6th component is a foot and footwear check. Foot problems, including reduced sensation, structural deformities, pain, and inappropriate footwear, are recognized fall risk contributors that are often overlooked. A fall risk assessment should include a brief look at the feet and a question about what footwear you typically use at home and outside. The 7th component is a home environment discussion, or in some cases, a formal home safety assessment. The home environment is where most falls among older adults occur, and hazards such as loose rugs, poor lighting, lack of grab bars, and cluttered walkways are modifiable risks that a clinician can ask about and a referral to occupational therapy can address in more depth through a formal home visit and assessment. Now, I also want to mention 2 questionnaire-based tools that are sometimes used alongside the physical test. The first is the Activities-Specific Balance Confidence Scale, often called the ABC scale. This is a 16-item questionnaire that asks you to rate your confidence in your balance across a range of everyday activities, from walking around the house to walking on icy pavement. Research has found that low balance confidence is itself a meaningful predictor of falls because it often leads to activity restriction, which, as I discussed in the Fear of Falling video, can itself increase physical fall risk over time. The ABC scale gives the clinician a picture of your psychological relationship with balance alongside the physical measurements. The second questionnaire tool is the Falls Efficacy Scale, which similarly assesses confidence in performing daily activities without falling. Both tools are validated and used in research and clinical settings. They provide information that the physical tests cannot about how you perceive your own capability. and about whether fear or reduced confidence may be contributing to your situation. Now, let me talk about where a fall risk assessment can happen and who can conduct one, because I want to make this as accessible as possible. The most comprehensive fall risk assessments are typically conducted by physical therapists who specialize in older adult care and who have training in the full range of tools I have described today. A physical therapist can administer all of the physical performance tests, conduct a detailed balance and gait analysis, review medications and their potential contribution, and develop a specific, individualized exercise and intervention plan based on the findings. A referral to physical therapy for a fall risk assessment is something your primary care physician can provide. If you explain that you are concerned about your fall risk or that you have had a fall or near fall, the assessment can also be initiated in a primary care setting. Using the STEADY framework, which I described in a previous video, the 3 key questions and the physical tests, including timed up and go, 30-second chair stand, and 4-stage balance test, can all be done during a primary care visit. Some practices have integrated this into annual wellness visits for patients over 65. Others have not done so consistently, which is why knowing to ask is important. Now, I want to tell you what happens after the assessment, because the assessment itself is only useful if it leads to action. A good fall risk assessment produces a set of specific identified risk factors and a corresponding set of recommended interventions tailored to those factors. For someone with significant muscle weakness on the 30-second chair stand, the recommendation will involve a progressive lower body strengthening program, often with physical therapy. For someone with identified orthostatic hypotension, the recommendation may involve a medication review and specific behavioral strategies, such as pausing before standing, leg crossing before rising, and adequate hydration. For someone with balance deficits, on the 4-stage balance test, the recommendation will involve a balance-specific exercise program, such as Tai Chi for fall prevention, or the Otago exercise program. For someone with vision problems identified in the screen, the recommendation will be an eye examination referral. For someone with home hazards identified in the discussion, the recommendation may include an occupational therapy referral for a home safety assessment and modification guidance. The point is, each finding produces a specific recommendation matched to what was found. This is what makes a formal assessment more useful than general advice, because it tells you specifically what your risk factors are and specifically what to do about them. Now, I want to briefly address something about frequency. How often should a fall risk assessment happen? The CDC's STEADY guidance recommends that fall risk screening, using at minimum the 3 key questions, should happen annually for adults 65 and older as part of their regular primary care visits. Beyond annual screening, a more detailed assessment is appropriate following any fall or any near fall serious enough to cause concern, following a change in medication that may affect fall risk, following any health change, such as a new diagnosis or a period of illness or hospitalization that may have affected strength or balance, and any time you notice a change in your balance, gait, or confidence in moving around. These are all appropriate triggers for a fresh conversation about fall risk with your doctor. Now let me bring this all together into something you can act on after today. The first step, at your next appointment, ask specifically, I would like to have a formal fall risk assessment. Can we do the timed up and go, the 30-second chair stand, and the 4-stage balance test today? Or can you refer me to physical therapy for a comprehensive assessment? Name the tests by name. This tells your doctor exactly what you are asking for and gives the conversation a clear direction. The second step, before that appointment, think honestly about the three key questions. Have you fallen in the past year? Do you feel unsteady when standing or walking? Do you worry about falling? Bring your honest answers. And if you have fallen, try to recall the circumstances. What were you doing? Where were you? Was there a specific trigger? That information is useful to the assessment. The third step, bring a complete list of everything you take: prescriptions, over-the-counter medications, vitamins and supplements, and be prepared to ask, could any of these be contributing to my fall risk? The fourth step, if a physical therapy referral is offered, accept it. A physical therapist can conduct the most comprehensive assessment and is best placed to develop the individualized exercise plan that follows from it. The fifth step, if a home safety discussion comes up, engage with it honestly. The home environment is where most falls happen, and simple modifications can make a meaningful difference. Now, let me close with something I feel genuinely. A fall risk assessment is not about labeling you as fragile or telling you what you cannot do. It is about getting specific about what is actually contributing to your individual risk, so that you and your doctor, and possibly a physical therapist, can address those specific things with specific interventions rather than general advice. The difference between knowing and your quadriceps are weaker than they should be for your age specifically versus hearing, be careful when you get up, generally, is enormous. One leads to an exercise program that builds that specific strength. The other leads to a vague caution. That changes nothing. You deserve the specific version. Ask for it by name. I am Dr. Chen. Thank you for spending this time with me today. If this gave you a clear picture of what a fall risk assessment actually involves and gave you the words to ask for one, please share this video with someone over 60 who has never had one. They deserve this information. Leave your questions in the comments. I read every one, and I will see you in the next video. Take care of yourself.